Harry Potter in your house, don't you?
Yes, a remarkable young man, Helga. Where did I put that book? Ah! Guests! How delightful! Welcome, welcome!
Albert, see, Professor Dumbledore has welcomed our guests, and it's now time for us to welcome our panelists. Dumbledore Tintin. He is the head honor of Ministry of Magic, a respected member of the Wizarding Galaxy. A registered nurse, Master of Arts in Nursing, and a Doctor of Medicine. He is the part owner and review director of the Review for Global Opportunities. Please welcome Dr. Chris Solomon, RN, MAN, US, RN. Our next panelist is an expert in wand lore and a renowned wand maker. She is a dignified member of the Weaving Family, naval achievement, a registered nurse, and a Master of Arts in Nursing, a registered nutritionist, and an expert on medical surgical nursing. Ladies and gentlemen, Ms. Golda P. Manalili, RND, RN, US, RN. Our third panelist is an expert in the care of magical creatures. As a man, finished her graduate studies at West Madras University, currently taking her doctorate degree at University of St. Bacolod. Level 3 chairperson of Colegio Agustin-Bacolod, College of Nursing. She is none other than Ms. Cora Agustin-Bacolod, RN, MN. Our fourth panelist is the first person and recovered student seats the Mellifluous Council.
Inside the great hall, the Hogwarts Soul Choir was singing a very joyful song. The whole castle was eager to start another school year for Hogwarts. The Colegio, arms extended as if trying to embrace the whole hall. His mere presence emitting an aura of comfort.
Few years has been and a long, colorful history of effort, full of wisdom and dignity. Let this one be a critical of students. But these schools will never be aesthetical without the students. So let us welcome our beloved young research and researchers. By Ravenclaw, we're going to greet the rest of the hard workers who work here. Slippers, that shows some great position. At Gryffindor, where the Ravens work hard, far above the rest. Welcome back, students. You have endeavored a great deal of culture for the past year, and I congratulate you all for proving yourself worthy of the honor, for being a student of Hogwarts. Now, as your perseverance climbs further up the pedestal, you're ready to face more punishment. But wither your spirit, for we shall be at your disposal tomorrow. Together with your professors, I once again welcome you all. May your courage to learn and harness the power of magic continue to blaze up until this graduate. For our first year, we welcome you to your second group. Level 40, begin! picture. Let us hear from Professor Dolores Numbers.
So much, headmaster. What a kind words of wonder. And how lovely to see your happy bright faces smiling at me. I'm sure we're all going to be very good friends. Always consider the education of young witches and wizards, and a certain objective has been made. Within 240 hours, in making the grand case presentation, we, the BSN 4B students, will be able to, for our knowledge, first, generate a comprehensive conceptual framework of ESRD, secondary to diabetes mellitus type 2, its process and management based on the medical surgical lectures. Second, outline comprehensively the pathophysiology of end-stage renal disease in relation to diabetes mellitus. Third, construct an adequate nursing diagnosis based on the patient prioritized problem. Fourth, categorize the problems identified into physiological, behavioral, actual, or potential. Fifth, devise an effective plan of care appropriate for the patient's condition, giving more focus to the prioritized problem.
Now, let the please
Out of nowhere, a dark owl with menacing look was carrying a small package. It was swooping into the Gryffindor table and dropped the package right in front of Harry. Everyone was dumbstruck by the surprise package. Even the teachers were lost for words. Then, Harry came to his senses. But before he could even touch the package,
No, Professor.
Mr. Reed, when was Dr. Cameron Allen Harold in university?
Yes, Professor. But he was looking rather different.
Please stand up.
all five took a few steps back. Then, Dumbledore was about to open it, but unexpectedly, they saw Dumbledore lying on his back. He looked pale, cold sweats were all over his body, and his breathing was shallow. He looked as if all energy was sucked out of his body. And on the floor was a shining crystal ball. From
possible way. While Snape took the crystal ball to his office.
Rough toenails, and on the face, I have stroked 10 times and asked him on the 5th time if he felt it. That he responded. Therefore, I conclude he has a delayed response to touch on both sides of the face. And he's unable to raise his eyebrows and puff cheeks and able to smile, and not unable to smile. Then, his eyes, in the inner ring of his conjunctiva, is already pale. There is diminished vision, loss of visual acuity, and cannot see the single eye. On his nose, there is a tube for his spitting. And on his mouth, the lips are already pale and cracked. The tongue is already pale, cracked, occupied, and cannot protrude it out completely. There is diminished sense of taste and difficulty of swallowing. He can hear me spoken words 2 feet away from him, but can hear me 5 to 6 inches away from his ear. And when he breathes, there's limited of extension. There is barrel chest, an increase in anterior posterior diameter of the chest. There is dullness upon percussion and crackles upon auscultation. There's an increased apical impulse diameter. There's a weak peripheral pulses except the arm where the ABF is located. As I touch the ABF side, there is thrill and brewing upon auscultation. And on his abdomen, there is fluid retention of both glands. There is dullness upon percussion, and there is glistening on the upper area of the abdomen. The abdominal girth is 88 centimeters. He cannot able to stand and perform cerebral function tests. There is weakness, placidity, decreased muscle strength, and diminished but present reflexes on the legs and the right arm. There is an atrophy of the left femoral muscle and the left calf muscle. There's an unequal measurement between the right and the left extremity. That's all, Madam Pomfrey. Madam Pomfrey, what can you say about Professor Dumbledore?
According to my assessment, Professor, the headmaster has a 15-year history of smoking 90 packs of cigarettes in a year. In addition, he used to drink 2 bottles of beer occasionally. These 2 vices were stopped after he was diagnosed with diabetes mellitus 29 years ago. Due to his diabetes mellitus, some complications arose like hypertension. The headmaster has a family history of diabetes since his elder sister died because of diabetes complications. Back in 1990, the headmaster was diagnosed with glaucoma and opted to have iridotomy in Manila after several years. But according to his wife, the operation wasn't successful. Back in 1999, according to his wife, the headmaster experienced mild stroke, but there were no retrieved records regarding this diagnosis. Back in 2001, the headmaster underwent an operation called transurethral resection of the prostate after he was diagnosed with benign prostatic hyperplasia. The headmaster had various occupations in the past. He became a carpenter, a fisherman, a welder, and a supervisor of a machine shop. He was a father of 9, and that he tried his very best to send them all to school. Before he was diagnosed with several of his diseases, the headmaster was very hardworking and preoccupied with his responsibilities, that he would usually skip meals of breakfast and lunch just to finish his duties. However, he would consume a large amount of rice for dinner to compensate the skip meals that he had. According to his wife, the headmaster experienced an excessive of being excessive side. But after he was diagnosed with his diseases, the headmaster started to do the schedule for 15 minutes daily before going out for work. In the last 2010, the headmaster went in and out of the hospital due to different complaints. And in November 2010, it was time that we took care of the headmaster. The headmaster was then diagnosed with end-stage renal disease secondary to DM nephropathy. And on the same month also, he was advised to undergo dialysis twice a week. When we had our assessment on August 14, 2011, the headmaster was already bedridden and was dependent on his family, especially to his wife, who he considered as his main support system. The headmaster was still continuing his dialysis, but because of weakness and fatigue and other circumstances, like the long travel time from their place to the hospital, he wasn't able to complete the sessions that was first advised him. The family also bought their own oxygen tank to be able to manage the exertional dyspnea the headmaster experiences. And last August 20, 2011, because of loss of appetite, the headmaster was put on NGP. Now, the headmaster's family has gradually accepted the things that are happening in the present and might happen in the future. That's all, Professor.
Thank you, Madam Conklin. But Professor, you do know you're right. No, Professor Nick does. He's working on it right now. Let's go.
Outside the door, Harry, Ron and Hermione were eavesdropping, obviously going against McGonagall's orders. And after they had heard enough, they immediately rounded the other members of the Dumbledore's army in the library. But moaning Myrtle saw them while roaming the hallway before turning to her cubicle to get her feet on. Then she told McGonagall about the meaning of the Dumbledore's army. McGonagall burst in the library and everyone was caught off guard.
What is the meaning of this? Aren't you supposed to be a dormitories? We know what happened with the headmaster. Yes, I do understand we're still the great hall when it happened. No, Professor, you don't understand. We know it was a curse. The more you stay with your dormitories in the house. But Professor, if Voldemort has cursed Professor Dumbledore, then we want to help. Very well. Colonel, can you please call Professor Snape and Professor Flitwick to come here?
Professor Snape! Professor Flitwick! Come to the library very quick!
After a few moments, Snape and Flitwick came in with Mercy.
Yes, Professor. Where's the lady, Professor? Can you please describe the topic of college with the curse? Is it proper in the presence of his insolent fools? Please, Professor, they can be of great help.
I could be of great help too, Professor. I know I'm My mother died because of diabetes mellitus. According to the American Diabetes Association, diabetes mellitus
our Lord himself. Only he and few loyal followers know the cure. What do you think so?
And that includes you, right, Professor?
As I was saying, this curse was made with the Dark Lord himself. Only few knew the cure, but even so, it doesn't guarantee a full recovery. The Mellifluous curse was contained in a crystal, thus giving rise to its name, Mellifluous crystal. It will affect the person nearest to it when its curse will be unleashed. Let me explain to you the pathology of diabetes mellitus and end-stage renal disease, so that Harry Potter's mind will understand. First, let us discuss first the affectation organ of the curse or the diabetes mellitus. Pancreas is an organ located beneath the stomach in the level of L2. Inside the pancreas, there is an island. 1 to 2 million islands holds the island of Langerhans. There are 3 kinds of cells in the island of Langerhans. First, the alpha cell which secretes glucagon, then the beta cell which secretes insulin, and the delta cell which secretes somatostatin. In response to hyperglycemia, the beta cell will secrete insulin. Then insulin will bind the receptors of the receptors in the cell membrane of the cell, leading to the facilitates the entry of glucose inside the cell for metabolism. Then it will decrease the blood glucose level. As in the case of the headmaster, being an Asian, age of more than 45 years old, and having a sibling of type 2 GM will predispose him to have the diabetes mellitus. But, Professor, do you know cure? I don't understand your question. Okay, let me continue. Okay. As we know that this factor will mutate the receptor of insulin in the surface of the cell, leading to decreased insulin sensitivity, thus it will cause insulin resistance. There are also factors that will precipitate the condition of the headmaster. As you observe, the headmaster is always under stress. When he is under stress, it will be sent by the hypothalamus. The hypothalamus will secrete corticotropin-releasing hormone, and it will stimulate that anterior pituitary gland to release adrenocorticotropic hormone. This hormone will stimulate the zona fasciculata of the adrenal cortex to secrete cortisol. Cortisol will have 2 effects. First, cortisol will increase glycogen breakdown in the brain, in the liver. Then, it will also facilitate gluconeogenesis. Gluconeogenesis is the formation of carbohydrates from glucose from non-carbohydrate sources, leading to hyperglycemia. Another factor is the headmaster has truncal obesity. As in the book of Pathology of Force, it is discussed that people with truncal obesity have decreased adiponectin levels in the body. When they decrease adiponectin levels in the body, there will be decreased sensitivity to insulin, leading to insulin resistance. Another factor that is affected by truncal obesity is increasing fatty acids, free fatty acids. A free fatty acid is which facilitates the increased fatty glucose production, decrease peripheral utilization of glucose, and therefore it will increase blood sugar level. Also, a chronic increase in blood sugar level will stimulate for the insulin and the pancreas to release insulin. If the pancreas will be secretor of insulin in the long time, excuse me, my joke is to continue. The beta cell will be exhausted, leading to decreased secretion of insulin. All these factors, I forgot, there's another factor. As you have observed, the headmaster is fond of skipping meals because of his work. Then he will eat too much leading to sudden increase in blood sugar levels. All of these factors increase the blood sugar level of the headmaster, leading to hyperglycemia.
Excuse me, Professor, but I think I should share with you the information that I was able to obtain from his diagnostic test.
Yes?
One of which is his random blood sugar that shooted up to 357 milligrams per deciliter. And with that, the doctor prescribed him with vildaglutine, metformin, and pioglitazone hydrochloride.
Quiet. As I continue, hyperglycemia will have an effect on the body. First, hyperglycemia will increase the serum osmolality. When there is increase in serum osmolality, it will shift the fluid from intracellular to intravascular space by the law of osmosis, since glucose is highly osmotic substance. It will lead to cellular dehydration. That includes the third center in the hypothalamus. Then the hypothalamus will stimulate the body to increase thirst or excessive in drinking of water, leading to molydipsia. Another is, if the blood glucose level surpasses the renal threshold of 180 to 200 milligrams per dl, the kidney will compensate by increasing the excretion of glucose in the kidney. Thus, the presence of glucose in the urine is called glycosuria. Another, the kidneys also. In response, the kidney will when the glucose will be out the urine, water will follow because of the law of osmosis, leading to increase in urine output or polyuria. As I continue, increase in sugar level in the blood will also increase blood viscosity. If there is increase in blood viscosity, the heart will increase its workload because the heart cannot pump well because the blood is too viscous. Then, what's the word again?
There is resistance, I think.
Oh yeah, there's resistance in the pumping action of the heart, leading to hypertension. Hypertension will damage the tunica intima of the blood vessels, specifically the aorta. Thus, it will trap clotting factors and platelets, leading to formation of plaques. This plaque will be best manifested as
atherosclerosis. I saw it in one of his radiologic exams in his chest x-ray. It was last January 18, 2011. There was presence of atherosclerotic aorta.
very good description. Then, the atherosclerosis will decrease the lumen size of the blood vessel, leading to increase in peripheral resistance, thus worsening the hypertension. Chronic increase in the workload of the heart due to increase in blood viscosity will enlarge the heart chamber, specifically the ventricles, leading to cardiomegaly and hypertrophy. Once there is hypertrophy, there will be decrease in size of the chamber of the ventricles and also decrease in stretching, leading to decrease in the amount of blood to pump from the heart, and there will be decrease in cardiac output. Decrease in cardiac output will be best manifested by,
Excuse me, Professor.
yes?
According to my research, there will be pale nail wax, a pale conjunctiva, a pale tongue, and what? A big peripheral pulse.
What is the manifestation of cardiomegaly?
In the case of the headmaster, cardiomegaly will cause increase in apical impulse to the liver.
Very well.
Excuse me, Professor.
Oh yeah?
But I also saw it in his radiologic exam.
X-ray result showed that he had Agustin-Bacolod.
There is a third time you're speaking out of your exposure. Are you incapable of restraining yourself? Or you're taking pride of being an inseparable know-it-all? 5 points from Gryffindor. I continue. Chronic increase in blood glucose level will lead to diabetic complications. Diabetic complications include the microvascular or the microangiopathy. It will affect the small blood vessels of the eye, kidneys, and the nerves. Repeat, Professor. How can diabetes mellitus affect the small blood vessels of the nerves, the eyes, and the kidneys? We must understand that microvascular or the small blood vessels in our eyes, kidneys, and nerves has a capillary frequency mercury. When there is increase in blood glucose level, there will be formation of abnormal glycoproteins. Glycoproteins is present in the capillary basement membrane of the endothelium. When there is chronic increase in blood glucose level, these glycoproteins, abnormal glycoproteins, will accumulate in the capillary basement membrane, leading to capillary basement membrane thickening. First, I'm going to discuss to you the diabetic neuropathy. When there is increase in abnormal glycoproteins in the nerve supplying the nerve, in the blood vessel supplying the nerves, it will decrease perfusion and diffusion of oxygen in the cells of the nerve, in the nerve cells. Ischemia of the nerve, leading to injury to the nerve, and neural death. Also, it will increase the conduction of the nerve. Wait, Professor, I'm not yet done. Also, increase in abnormal glycoprotein will increase in the amount of sorbitol. Sorbitol will be accumulated in the nerve cells, leading to slowing of conduction of impulses. So, when there is peripheral neuropathy, especially the synaptic cortex, synaptic type, in the motor, cranial nerve 7, facial, there is the headmaster is unable to raise his eyebrows and unable to smile. And cranial nerve 9 and cranial nerve 10, glossopharyngeal and vagus. The headmaster has difficulty of swallowing or speaking. Cranial nerve 12 or hypoglossal. The headmaster has unable to protrude its tongue completely. And for the sensor, cranial nerve 7, facial, there will be delayed response to touch on both sides of the face. And cranial nerve 5 and cranial nerve 9, facial and glossopharyngeal, there will be diminished sense of taste. Thank you, Professor Fusby. Let us now proceed to another complication or microvascular complication, also known as diabetic retinopathy. The same mechanism was explained because there is also abnormal accumulation of glycoprotein in a capillary basement membrane that supplies the retina. When there is decrease in perfusion, there will be decreased perfusion to the retina. In response, the eye will facilitate the formation of new blood vessels. But this new blood vessels include the canalus cleft and trabecular meshwork. As you all know, the canalus cleft and trabecular meshwork is responsible for the drainage of aqueous tumor to the venous circulation. If there is an occlusion in the trabecular meshwork and canalus cleft, there will be the accumulation of aqueous tumor in the anterior chamber of the eyes. When there is accumulation of this aqueous tumor, it will increase the intraocular pressure leading to glaucoma.
Excuse me, Professor.
Yes?
We all know that the head master manifests sudden vision. Am I right?
Definitely. As I continue, increasing intraocular pressure will compress the neural layer of the retina, leading to retinal ischemia, leading
complication of diabetic mellitus, which greatly affects the formation of end-stage renal disease. According to Bruder and Sudhart, the number one cause of end-stage renal disease is linked to diabetes mellitus. It may explain to you the morbid pathology of development of microvascular complications in the kidney or the diabetic nephropathy. First, the same mechanism was utilized. The same mechanism was used or utilized in the formation of this nephropathy. Will also create abnormal glycoproteins. It will be deposited in the, okay, excuse me, my mouth is too dry. Sorry for that. Continue. The abnormal glycoproteins will be deposited in the capillary basement membrane of the glomerulus. I understand the question? Yes. The capillary basement membrane of the glomerulus, leading to decreased perfusion in the glomerulus and nutrition in the glomerulus, leading to injury and ischemia of the glomerulus. Also, decreased perfusion facilitates the, what's the word again? Students, turn to page 394.
Filtration.
Okay. What again?
Filtration. Filtration.
What's filtration? Can you complete the sentence?
Infiltration.
Oh. Continue. There will be glomerulosclerosis. Also, what is the cause of glomerulosclerosis? When there is a decreased perfusion to the glomerulus or because of the capillary basement membrane thickening, there will be the proliferation of the intercellular, the mesangial matrix of the kidney. The mesangial matrix of the kidney is located between the glomerulus. When there is proliferation of mesangial cells, there will be increased expansion of this matrix, leading to occlusion in the glomerular arteries, leading to injury to the nephrons. As we all know, there are stages of chronic kidney disease. All of these factors will lead to the damage to the nephrons, leading to destruction of nephrons. Once the nephron is destructed, also the patient will not immediately manifest the signs and symptoms. When there is decrease in glomerular filtration rate of less than 50%, the patient will start to manifest the signs and symptoms. First, if there is decrease in glomerular filtration rate of less than 50%, it is termed as diminished renal reserve. The healthy nephrons will compensate by increasing its permeability. Because they compensate, there is hypertrophy of remaining nephrons. The hypertrophy of remaining nephrons will have the leak of plasma proteins in the albumin in the urine, leading to proteinuria.
Professor,
yes?
if I may say, our headmaster also underwent a urinalysis, and it was, I saw it there that his result was positive too, which means that there's turbidity with granulation but no flocculation.
Very good, Miss Granger. As I see it, also there's the RBC will also pass through the pillow because the kidneys because the nephrons are hypertrophied rather. Wait, try now again. To continue, the presence of RBC in the urine or also termed as hematuria is because the RBC will pass to the slits because the slits are enlarged because of hypertrophy.
That's why there were 100 red blood cells in his urine.
Thank you, Ms. Ranger. As I continue, further compensation of the nephrons, it will also overwork the nephrons, leading to decrease also in glomerular filtration rate. If the glomerular filtration rate is less than 35%, this is referred as renal insufficiency. Further loss of glomerular filtration rate will also decrease the glomerular filtration rate into less than 25%. It is referred as renal failure. And the last, but not the least, the most disturbing of all and the most scary of all. When the glomerular filtration rate is decreased into less than 20%, or some books say that it's less than 10%, it's the end-stage renal disease. The end-stage renal disease is marked with decrease in the renal function. The renal function has two functions. First is the excretory renal function. Second is the non-excretory renal function. First, I will discuss the renal excretory renal function. First, as you all know, the kidney is responsible. The kidney is responsible. I forgot the term. Responsible for excretion of waste products. Oh, that's correct. These waste products are the products of protein metabolism. Usually, they are the creatinine and BUN. Because of the damage to the glomerulus and the nephrons, will be decreased in the excretion of these waste products. These waste products will accumulate in the blood, leading to uremia. Uremia is best manifested by increase in blood urea, nitrogen, and creatinine.
Professor, I also saw it in his diagnostic test that his blood urea nitrogen shooted up to 156 milligrams per deciliter, and his creatinine level was 5.6 milligrams per deciliter.
Specifically, can you say to me signs and symptoms related to uremia?
So, there will be anorexia, and there will be increased capillary permeability. So there will be excretion, so there will be deposition to the skin. Then it will alter the glandocytes, and it will alter the glandular formation, leading to hyperpigmentation.
Okay, thank you, Professor. Next is the function of kidney is for urine formation. Usually the kidney is forming urine of 100, Kidney is responsible for forming urine to 30 cc per minute, or in the whole day, and the 24 hours, it's 720 ml per day. Once there is decrease in renal function, the kidney is not able to form adequate urine because there is decrease in tubular secretion of urine and decreased concentration of this water, leading to decrease in urine output. Olivia, manifested by?
Excuse me, Professor. Headmaster's urine output was also monitored. As of August 14, 2010, its intake was 1,000 ml, and the output was 220 ml. And as of August 26, 2010, its intake was also 1,000 ml, and the output was 230 ml. And as of August 2, 2010, the intake was 1,000 ml, and the output was 220 ml. And lastly, as of September 9, 2010, the intake was still 1,000 ml, and the output was still 220 ml.
Thank you. Furthermore, also one of the function of kidney is the regulation of extracellular fluid.
May limitation lang. May 5,000 lang dapat ang
Because of decrease in renal function, there will be decreased excretion of water.
800.
Decreased excretion of water will lead to water accumulation in the body. It will increase its fluid volume. Increase in blood volume. Decrease in blood volume will increase the hydrostatic pressure in the blood. Hydrostatic pressure is the pressure that is the weight of the fluid that is exerted in the blood vessels. To increase in the hydrostatic pressure, there will be shifting of fluid from intravascular to interstitial cells, leading to
that will be manifested by edema, right, Professor? Specifically periorbital facial edema, and that will lead to ascites, which will cause turbulent abdomen, a decrease in undetectable underlying structures, and decrease and dullness upon percussion. Is that right, Professor?
Professor, I also remember that he was given with furosemide or a diuretic. However, this was stopped when he was diagnosed with chronic renal failure and he was advised to undergo dialysis.
Thank you. If there is increase in blood volume, there will be the compensation of the heart is increasing its contraction, leading to increasing cardiac workload. If there is increase in cardiac workload, there will be resistant cardiac workload. There will be formation of or hypertrophy of the ventricles, leading to cardiomegaly and hypertrophy. If there is hypertrophy, it will increase in the ventricular pressure. The ventricular pressure cannot be, what's the word? Oh. The ventricular pressure will be shunt towards the left atrium. The left atrium will also shunt its pressure into the pulmonary veins. The pulmonary veins, there will be increase in pulmonary pressure. Where there is increase in pulmonary pressure, there will be shifting of fluid from intravascular to interpleural spaces or interpleural space, leading to what is it called this? Pleural effusion. Pleural effusion. There is abnormal accumulation of fluid in the pleural cavity.
Professor, it was always shown in his chest x-ray that last June 19, 2011, there was this mild pulmonary congestion and bilateral minimal pleural effusion.
Okay.
And to add to that, he was prescribed with levofloxacin as a prophylaxis for respiratory infections.
Continue. An increase in capillary pressure and the capillary pressure in the pulmonary veins. The lungs will be congested, leading to pulmonary congestion. Pulmonary congestion. Ms. Granger, what's the X-ray of the patient?
As I said a while ago, Professor, that last January 19, 2011, he was shown with mild pulmonary congestion.
Thank you. Pulmonary congestion in the peritubular capillaries in the kidneys, leading to loss of sodium in urine, termed as natriuresis. When there is decrease in serum sodium, also, there will be hyponatremia.
Hyponatremia was less manifested or supported by his diagnostic test the serum sodium level was 119.80 milliequivalent per liter.
Thank you. When there is decrease in serum sodium, first, there will be let's do it again. Decrease in serum osmolarity. As we all know, the serum osmolarity is the concentration of blood. There will be shifting of fluid from intravascular to interstitial space, leading to edema again. Right?
Yes.
Then, this decrease also in sodium will decrease the uptake of sodium in the sarcolemma of the muscle. Because the decrease in sodium stimulates in the sarcolemma of the muscle, there will be decrease in action potential, leading to muscle weakness because there is decreased contraction of muscles. As you all know that sodium is responsible with the contraction of muscles. It is best manifested by what?
It is best manifested by fatigue, muscle weakness, and decreased muscle tone and muscle strength, which will lead to decreased bed mobility, Professor, as manifested by our head muscle.
Okay,
that's all.
Also, there's decrease in the contraction of muscles. It will also follow that there is decrease in, because in the GI tract there is also a muscle. It is called the smooth muscle. There is also decrease in the simulation of smooth muscles, leading to decrease in GI motility. Decrease in GI motility will be manifested by what?
Anorexia, sir?
Yes, what again?
I think his anorexia was corrected by the drug that was given to him, which was buclidine hydrochloride. This is to enhance his appetite so that his intake will increase.
Thank you. Another is, one of the functions of the kidney is to regulate the acid-base balance. In the renal disease. There is decreased excretion of bicarbonate ions and increase in the absorption of hydrogen ion, leading to metabolic acidosis.
Professor, it was a good thing that our headmaster's body compensated with this metabolic acidosis because his arterial blood gas analysis showed that his partial pressure for carbon dioxide was 27.1 millimeter mercury and his bicarbonate level was 15.7 milliequivalents per liter. And with that, his body was able to normalize his serum to 7.37. However, the doctor still prescribed him with sodium bicarbonate. This is for his body so that it will correct the metabolic acidosis.
Okay, one of the last function of the kidney for the excretory renal function is the regulation of electrolytes balance. When there is decrease in renal function, there will be increased excretion of wait. I'm so distracted with the Mellifluous curse. It affects my brain. I'm so confused. Okay, I remember now. There's decrease in excretion of potassium in the kidneys, leading to increased potassium in the blood. It is referred as the term as hyperkalemia.
Hyperphosphatemia, I think.
Hyperkalemia.
Hyperkalemia. Yes, I remember that his calcium level was, his potassium level, was 6.446 milliequivalents per liter.
Also, the kidney is responsible for the regulation of serum electrolytes, specifically the phosphorus. If there is decrease in the renal function, the phosphorus will not be excreted through the urine, leading to decrease in serum phosphate or hyperphosphatemia.
Hyperphosphatemia can also be supported by his laboratory finding, which his serum potassium level was 6.46 milliequivalents per deciliter.
Thank you. Increase in potassium level, increase in phosphorus level in the blood will decrease serum calcium. Why? Because calcium and phosphorus is inversely proportional with each other. If the phosphorus will increase, the calcium will decrease. If the calcium will increase, phosphorus will be decreased. In the case of hyperphosphatemia, there is decrease in calcium level in the blood. The parathyroid hormone will compensate by increasing by secreting parathyroid gland. The parathyroid gland will be secreting its parathyroid hormone. Parathyroid hormone is the hypercalcemic agent. It will increase bone resorption, leading to renal osteodystrophy. Another is increase in phosphate in the blood. There will be deposition of phosphate in the skin, leading to hyperpigmentation. Let's go now to the loss of non-excretory renal function of the kidneys. One of the functions of the kidneys is the formation of blood products. Specifically, I'm sorry, I'm wrong. One of the functions of kidney is to secrete a specific hormone which is called erythropoietin. Erythropoietin will stimulate the bone marrow. Okay, that's the term. The bone marrow to produce RBC. Since there's decrease in renal function, there's decrease in production of erythropoietin, leading to decrease in secretion of erythropoietin, then decrease in secretion, decrease in formation of RBC, leading to decrease RBC count in the blood, leading to anemia.
Yes, Professor. It was perfectly manifested by our headmaster because in his hematology test, his red blood cell count was 2.91 times 10 to the power of 12 per liter, and his hemoglobin count was 104 grams per liter, and his hematocrit level was 0.31. And with that, the doctor prescribed him with a multivitamin that contains ferrous fumarate, folic acid, and cyanocobalamin. This is to faster the rate of maturation of the red blood cells so that it can correct the anemia.
Okay.
He also received a poison alpha after his dialysis.
There is decrease in RBC in the blood because RBC is the one that is carrying the oxygen toward the cell. So the decreased perfusion in the peripheries. Decreased perfusion in the peripheries will lead to this manifestation. What is this Mr. Lee Jordan?
According to my research again, there will be a body malaise, a fatigue, and body weakness. Plus, there is a capillary bill of 4 seconds. Plus, a pale conjunctiva. Plus, a pale nail red. Plus, a pale tongue. That's all, my professor.
Right point for Ravenclaw for that answer, Miss Lee Jordan. Mr. Lee Jordan, rather. Also, there will be decrease in perfusion in the brain, leading to neurologic manifestation. What is neurologic manifestations?
Such as irritability, restlessness, and confusion.
Okay. There will be also decrease in perfusion to the cells and tissues and muscles of the peripheries, leading to what manifestation? Pardon. Oh, it's already finished? The fatigue?
Yes.
Okay, thank you. Let's go now to another function of the non-excitatory renal function, which is the activation of vitamin D. As we all know, the kidney is responsible for the activation of vitamin D into 1,2,5-dihydroxycholecalciferol. Since there is decrease in renal function, there is decrease in activation of inactive vitamin D to 1,2,5-dihydroxycholecalciferol. When there is decrease in 1,2,5-dihydroxycholecalciferol, there will be decrease in absorption of calcium in the intestines, leading to hypocalcemia.
Hypocalcemia can be manifested by the client in his laboratory finding, which was 7.44 milliequivalent per liter. He also receives calcium carbonate to correct his hypocalcemia.
Thank you. One of also function of kidney is the metabolism of insulin. Once insulin is not properly metabolized, there will be resistance in the insulin in the peripheries. There will be abnormal insulin in the blood, leading to erratic blood glucose level, leading to hyperglycemia. Other function of the kidney is the activation of androgens. If there's decrease in androgen in the body, there will be testicular hypertrophy, as what Professor Dumbledore has manifested. In overall, that's my physiology, Ms. Granger, and I'm Professor Bacolod. I'm so tired of speaking here in front, so I will take rest now.
Thank you so much.
Thank you so much, Professor. And welcome, students. Now, I'm talking with and Professor Peter about certain problems that need immediate intervention. So you can just listen. The headmaster's first prioritized problem is fluid retention. And under fluid retention, the problems are water retention, hypertension, bipedal edema grade 3, pleural effusion, pulmonary congestion, cardiomegaly, hyponatremia, proteinuria, anorexia, constipation, dysphagia, decreased muscle tone and strength, muscle atrophy in both extremities, and disruption in role performance. For this, the actual physiologic problem is excess fluid volume related to decreased renal fluid excretion secondary to the nephropathy. The second prioritized problem regarding Dumbledore's case is anemia. And under anemia, the problems are disorientation, irritability, body weakness, decreased circulating RBC, exertional dyspnea, disruption in role performance, fatigue, lethargy, anorexia, altered thought process, immobility, restlessness, muscle atrophy in both extremities, and decrease of muscle tone and strength. For this, the actual physiologic problem is infected peripheral tissue perfusion related to decreased circulating RBC secondary to VM nephropathy. The third physiologic problem regarding Dumbledore's case is malnutrition. And under malnutrition, the problems are anorexia, dysphagia, body weakness, muscle weakness, hyponatremia, altered role performance, and fatigue. Regarding malnutrition, physiologic problem is imbalanced nutrition less than body requirements related to DM nephropathy. And that is all.
Actually, Professor, we have identified the problems you prioritize, and we've already formulated our care plan for our headmaster. Go on, Ron, tell him.
Well, Professor, thanks to Professor Flitwick's and Madame Pomfrey's assessment, and with your problem, Professor McGonagall, we've come up with an NCP for the nursing diagnosis of excessive fluid volume related to decreased